Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, everyone. My name is Brooke Seam, and welcome to the Mad in America podcast. I am the author of May Cause Side Effects, and today I have Dr. Paul Andrews, Associate Professor of Evolutionary Psychology in the Department of Psychology, Neuroscience and Behaviour at McMaster University. His research focuses on understanding the evolution of depression, which he argues may be an evolved emotional response for understanding and solving complex problems. Dr. Andrews is also concerned with the evolution of the serotonin system and the effects of antidepressants on mental and physical health. His research has shown an increased risk of cardiovascular events as well as death among those who use antidepressants. Paul, thank you so much for joining us today.
Well, thanks so much for having me on your podcast, Brooke. It's nice to be here.
I'm so excited to talk to you because I feel like when I came across your work, it put words to a lot of things that I feel like I knew intuitively, but one, didn't have any words for, and then also didn't know anyone was researching. And so I want to start with a quote from a writer named Maggie Nelson. She came out with this beautiful book that I recently read called Bluets, and there was a line that stuck out to me, and it feels very, very appropriate to your work. The quote is, "It often happens that we treat pain as if it were the only real thing, or at least the most real thing. When it comes around, everything before it, around it, and perhaps in front of it tends to seem fleeting and delusional." So as an evolutionary psychologist, taking that quote in mind, why do we feel pain?
Wow, that's a really powerful quote. I love it. We feel pain because as part of one single evolutionary tree of life, organisms from flies to mice to squid to humans all have threatening challenges that they face in their lives. Things that can kill them or interfere with their reproduction. And we need to be able to avoid them. And we need to be able to avoid the harms associated with them. So painful feelings, all of them seem to have a common property, and that is to promote what we can sometimes call avoidance behavior, which is to avoid threatening, harmful events in our lives. And also relatedly to that, to promote avoidance learning, which is not just how we behave, but learning how we can behave to avoid these threatening events. For example, really the simplest kind of thing is just to imagine when you have a sprained ankle, which all of us have had at one point or another in our lives. It's very, very painful. And the pain actually helps us keep our weight off of our ankle so that we don't injure ourselves further, and we actually give ourselves a chance to heal. So there's an avoidance of further harm, further damage to the injured ankle that is promoted by that painful feeling. And if you take any anti-pain medication in order to make it feel less painful, you're actually going to be more likely to put weight on the ankle, which will delay the whole healing process and could actually help promote further injury. I mean, I can say more about it, but I just wanted to start with like a physical pain thing as an example, because that's something I think we all can intuitively understand.
A physical pain for sure. It's very interesting because I've been dealing with, I tore my ACL and had full ACL surgery in the past couple months. So I've been spending a lot of time sitting with my own thoughts, noticing the difference between healing physically and healing emotionally. And so it's very easy for people to understand the analogy of physical pain, but I think we all get a little tripped up around emotional pain. It seems so much more complicated. It's not linear. So what is the evolutionary purpose of emotional pain? And more importantly, is that effectively a maladaptation in a world where most of us aren't struggling to, not get chased by lions and to be wiped out by famine?
It's a great question. Well, so thank you for saying let's do some more elaboration. Let's try and see if we can extend this concept of avoidance behavior and avoidance learning to other kinds of pain, including emotional pain. I actually like to build up to depression and anxiety. Let's not just immediately go there. Let's start with other kinds of pain that you'd consider more psychological. Okay, for instance, we can talk about the kind of malaise you feel when you're sick with an infection. It's not pleasant. It is distressing, painful, unpleasant. What is this doing? It's actually helping you. That malaise you feel is worse when you're actually physically active. So it actually forces you to stay in bed, rest up, and help your immune system take up all the energy it needs. So there's an avoidance type of behavior that's at stake with the painful, distressing malaise that you feel when you're sick with an infection. Maybe even more important is to think about when you're starving. Of course, most of us don't actually know what starvation is really like, but we know what it's like to be hungry. And when you're starving, you have this massive amount of hunger that is it's essentially intolerable. And it is designed to help you, motivate you to go out and find food so that you can solve the starvation problem. But in an avoidance language, it is avoiding the death that can be caused by starvation. That's what's the painful feeling is motivating. There are a whole slew of other kinds of painful feelings that we can talk about in avoidance language, like jealousy, right? Now, a lot of modern lay psychology likes to think about jealousy as a pathological kind of thing, but there are different kinds of jealousy, and reactive jealousy is actually a pretty normal thing, and it helps you. It's a sign that you actually value your partner. So if your partner is doing something that indicates to you that there may be some threat to the relationship, either an emotional threat or a sexual threat, it's common to have that experience of jealousy, and that jealousy is motivating you to actually pay attention to the situation and try and see if you can find something that can avoid that threat from coming true. And we can go down a whole list of things, but the problem with depression, and we can even talk about anxiety. We know that, social anxiety, for instance, is actually when you're afraid of being some negative consequence from engaging in social interaction, like embarrassing yourself. And so what it does do is that feeling helps you avoid being in those social interactions so that you avoid the costs of being embarrassed. Now, I'm not saying that that's all adaptive, right? Because social anxiety, it has that effect of helping you avoid the embarrassment of, that can come with social interactions, but it comes with other costs too. Like, you don't take advantage of social opportunities. You may be socially isolated, et cetera. And there's some issues with that. But it's easy to think about social anxiety in terms of avoidance behavior and avoidance language. So when we finally come to depression, what I would just say is, because we know that every other kind of painful feeling, from physical, perceptual painful feelings to these psychological and social ones, can be characterized in terms of avoidance behavior and avoidance learning, I would just say we ought to be looking for avoidance behavior and avoidance learning functions for depression. And it's like, no, most people don't even think about it. Most researchers don't even think about it in those terms. And so in my mind, it's a frontier area of science.
Can you give us an example of what that would look like? Because what I love about your work is that it's so broad, and we're really looking at these big, broad concepts that I think are largely ignored at the individual level. And at the same time, it's like, how does the individual use this information in order to get themselves out of their depressive episode or their anxiety episode or whatever they're in? So could you give us an example of how we could look for an avoidance behavior in an individual's depression that would help them find their way out in the context of evolutionary psychology?
Let me give you, I think, an example from the literature that helps make this point clear. And to me, it's just an extremely interesting body of literature because it has to do with physicians and psychiatrists and their own emotional reactions to, in the case of physicians, making a medical error.
So we're separating physician as in like a surgeon or an endocrinologist from a psychiatrist.
Well, yeah, but the story is the same. I'm just saying that when the case of a physician like a surgeon, the literature really focuses on their emotional reactions to making a serious medical error that hurts a patient, versus a psychiatrist who, in this case, has lost a patient to suicide and their own emotional reactions to that. But the story is the same. I just wanted you to sort of see the slight difference in the context. In the literature on emotional responses to medical errors, it's a very common thing. I mean, it's just due to the nature of the medical system and the fact that humans are imperfect. Hopefully, when they make a mistake, they learn from their mistake, right? That's what this literature is about, and what is required cognitively and emotionally for them to learn from their mistake. So basically, the story is the literature shows that, yeah, most physicians, when they make a serious medical mistake, feel a lot of emotional agony over having hurt a patient. And we also know that the emotional agony can reach clinical levels. It probably depends on how severe the mistake was and how severe the consequences are. But it's not uncommon for physicians who have made these kinds of mistakes to meet clinical criteria for depression, for acute traumatic stress, for generalized anxiety, and so on. The whole purpose of avoidance behavior and avoidance learning is to figure out what you could have done differently to change the outcome. So if we go back to the physician, if he concludes or she concludes that, oh, it was that stupid nurse's fault or the stupid, laboratory tech or somebody else other than me, well, that's not going to help me learn what I can do to reduce this chance in the future. So this kind of avoidance behavior is inherently self-blaming. It has to be self-blaming. Otherwise, it's not going to be effective in producing avoidance behavior. So one of the puzzling things for a clinician is, why, if rumination is supposed to help you solve problems, why does it have to be so self-blaming and self-deprecating? And the answer to that is it's hidden in the fact that it's designed to promote avoidance behavior and avoidance learning, which is all about what you could do. So you have to go searching back through that causal chain of events for things that you could have done differently.
I'm reminded of a comedian I saw on some podcast recently, and they were talking about just, the general poor mental health of Gen Z and whatnot. And the comment the comedian had was, sometimes I just think we need a little bit of a light famine in this generation, like something to just kind of wake them up to the reality of actual pain and suffering on a deep human evolutionary level, because it's like the marker for what is considered a crisis keeps getting softer and softer and softer. And so what I'm wondering is how we find this line between what is normal avoidant behavior, normal rumination to produce a positive response, a positive change in activity, versus this pathological thing that we seem to have going where everybody's brain is just broken, that there's these breakdowns and flaws in the system that aren't our fault at all. And it's like the rumination over this stuff, people just get stuck in these loops over really inconsequential things. Not so much a question as much as an interjection of, again, like, how do we bring this into modern society where most people aren't losing a child, most people aren't accidentally killing someone on a surgical table. Most people are trying to get over or seem to get over the girlfriend that broke up with them in college, and 15 years later, they're still ruminating and depressed about it.
One of the things that has happened is that psychiatry itself has changed. In the 70s, there was, and before, psychiatry had a greater influence of Freudian thinking, psychoanalysis, psychodynamics. And there was a backlash to that. And there was an attempt to expunge Freudian thinking from psychiatry. Now, certainly there was some of that was really useful because not everything that Freud had done was supported by the research. But one of the things that I think he did understand is that painful feelings are pretty normal. And my understanding from the research done by other colleagues like Alan Horowitz and Jerry Wakefield is that prior to the 1980 revision of the DSM, that the way depression and probably anxiety were viewed is that they were normal, the degree of pain you felt was not by itself an indicator of whether or not your brain was behaving normally. The psychiatrist would try to evaluate what's going on in your life, socially, situationally, and evaluate your pain in relation to that. If it was proportional, they'd say, well, it seems like it's a natural, normal response. Okay. And it was only if there was, the pain was disproportionate to the stressors in your life that it would be viewed as a problem, a mental health problem. And now we don't do that. We just go through, the field of psychiatry has, essentially produced a checklist of feelings, symptoms. And if you check off enough of them, then boom, you've got the disorder. And, I have a great example of why even serious, chronic, prolonged depression, that you would intuitively understand it as a normal response. And this is relevant to our question about how do we separate out the normal versus the pathological.
I don't even hate using the word pathological. It's just that what's commonly used in the lexicon. So,
well, yeah, but as an evolutionist, hey, look, you and I are both wearing glasses, right? That means our eyes can malfunction, and those are clearly evolved organs. Even if there's some adaptation in our brain for producing depression, of course it has to malfunction at some rate. I just don't think it's as high a rate as the diagnostic criteria are saying. So that's, again, my point is the real problem, as far as I can see, is how do we accurately distinguish between normal and pathological?
yeah, I don't want to go over this point too fast because I think it's really important. And this was one of the many aha moments I've had with your work, is that in general, organs don't fail all that often.
Especially during the reproductive years.
Yes. And yet we're busy creating this narrative that all these children have malfunctioning brains and all these young, reproductively healthy people have malfunctioning brains. And it's just like, you don't see people having heart disease or liver failure at 14 years old at a rate of 1 in 4. So this literally makes no sense. Agreed.
So let's go to this anecdote. This comes from a colleague of mine who published it. Her name's Joanne Cacciatore, and she's a professor of social work at Arizona State. And the anecdote is as follows. There was this young mother who was in her living room moving heavy furniture. And she thought that her 1-year-old daughter was in the kitchen playing. So the mother picks up this heavy TV set, tries to move it from one place to the other in the living room, and it starts slipping out of her hands, and the daughter was not in the kitchen after all. And the mother, by accident dropped the TV on the child, and the child died.
Horrible.
Yeah, incredibly horrible. But the reason why, I don't even think you need to be an evolutionist to understand a few points about this. Just go with your gut instinct. If this woman's brain is normal and she's not a psychopath, is she going to have some agony over killing her child? And I think the answer to that is yeah, massively. So is she going to meet the criteria DSM criteria for depression, 5 of 9 symptoms, which, we could go over, and the 2-week durational requirement. It has to be at least 2 weeks. Is she going to be depressed for 2 weeks? Oh, yeah. Is she going to be depressed for 2 months? Yeah. Is she, the thing is she may never, ever truly recover. Joanne's done some other work that shows that it's not uncommon for parents who have lost their children to still meet DSM criteria for depression 4 years after the loss of their child. And in the case of this woman, this is where the woman can clearly point to her own behavior as doing it. So that's why I say she may never really recover. The other part about this, and this is just my own personal perspective, and other people may differ, but maybe it's because I think of the avoidant learning part of this. I'm not sure I think it would be a good idea for her to completely recover. You don't want to see people living in misery for the rest of their lives. But if this thing happened to me, I'm not sure I would want to fully recover. I would always want to have, in some sense, in the back of my brain, I need to be careful, when I'm dealing with my kids. The other thing you can easily say is, just by intuition, is something like this going to happen again? If she's got a normal brain, and she experiences this agony for, prolonged period of time, you can bet that she is never, going to let something similar like that happen again. But more importantly than that, you'd probably think that a mother who's had this happen is going to maybe be ultra protective of her children from then on out, and maybe too protective. But again, that may not all be good, but you can clearly understand it in terms of that avoidance behavior and avoidance learning function. So I think that anecdote is telling, and it's another instance where it's just easy to demonstrate that if you contextualize things enough, it's easy to see how even severe and prolonged depressions can be normal.
So let's shift to your latest work. You were telling me before we started recording that you had just published a paper about how you successfully induced depression in the lab. And this is further ties into our discussion about how this probably isn't a brain disorder if you can effectively induce it at will, because we can't just look at someone and say, oh, snap your fingers, here's some fatty liver disease. It's not really how it works. So tell us a little bit about this research and what it could mean for the field of psychiatry moving forward.
I'll just sort of give you the context for why we developed this paradigm. There are various ways to induce sad mood through experimental means, but nobody has ever developed a paradigm for triggering depression, which is a syndrome. It's a collection of multiple symptoms that have the symptoms can be behavioral and cognitive and emotional, right? And that maps onto what we think of as DSM kind of depression. And the reason why it's important is because there's so many different arguments and hypotheses and beliefs about depression out there, ranging from the disorder narrative that we commonly think of to, evolutionary oriented hypotheses like my own that say this is a normal emotional response. And the debates really don't get to go anywhere because we don't have experimental control over the thing that we're studying. And so we were always having to do correlational studies or case control studies where we really can't address causality. Experimental paradigms where things are randomized, have randomized controls, are the classic way of addressing causal hypotheses. So the main point is that we essentially put people through a social rejection in the lab. It's somewhat deceptive because they're not actually being rejected by other people, but they don't know that and they think they're being rejected by other people. And the other component about this paradigm is that we give them reason to actually start thinking about doing a root cause analysis. Without going into detail, if you give them a reason to ask, is there something I could have done to avoid this social rejection? Then you can induce rumination.
Interesting.
And that's why we're not just inducing sadness. We published a paper using this paradigm, and we found out that we can increase sadness. We can also increase the symptom of anhedonia, which is, for your audience, if they don't know it, anhedonia is the loss of interest in normally pleasurable activities like sex and social companionship or humor, or the inability to feel pleasure in response to these normally pleasurable activities. We can induce the symptoms of guilt or self-blame. Those are, two words meaning the same thing in this context. And we can induce low self-esteem or the symptom of worthlessness. We have some evidence that this paradigm triggers difficulty concentrating, which is another symptom, although we want to test that more in the future. I'm not saying that we've met all of the formal criteria for depression, because that requires like 5 symptoms out of 9. We have no evidence we're inducing any suicidal ideation. Thank God, right? We don't want to be doing that in our participants. So we have about 4 symptoms out of the 9, but I will say that the sadness, the anhedonia, the guilt, and the worthlessness are some of the most core features of depression, whereas things like lethargy or restlessness or agitation, the sleeping changes and the appetite changes, they're not as crucial to that because they can happen with all sorts of other conditions as well. So we know we are inducing a syndrome because it's multiple symptoms, and they have cognitive and affective or emotional features, and they are some of the most important ones. Our samples are university students. Their average age is 18, so they're essentially in the beginning of their reproductive careers. We would think, for the most part, that if, in order to get into university, you have to be fairly healthy, you have to have fairly good working minds, right? And so the philosophical reason why this is a good sample for us is because, natural selection, as you were saying earlier, doesn't really tolerate high levels of dysfunction or somatic dysfunction, in our brains or our bodies during the reproductive years. As we get older and past reproductive age, all of us are going to die of some kind of malfunction eventually, and the rates of true disorders go up after the reproductive years. But so anyway, this is why, if we can trigger depressive symptomology in young, healthy people, that is an argument against it being a disorder. The other thing that we've got is, yes, some of these, too many of them, actually have formal psychiatric diagnoses. I find that problematic given what I just told you about, natural selection not tolerating high levels of this. But nevertheless, that a lot of them have, let's say 15 to 20% of them have psychiatric diagnoses, under the idea that they ostensibly have something wrong with their brains. We can exclude them from the analysis and see if the ones who don't have the diagnosis still show these symptoms. And we find no difference in the effect, which means, again, we are triggering this in now the most ostensibly healthy individuals in our population. So, our argument is that this is a normal response. That even the feelings of guilt and worthlessness, which I think worthlessness is one that psychiatry and clinical psychology view as particularly problematic, right? How could it be a useful, normal thing to feel like you're a piece of crap? I mean, actually, there is an answer to that question, and it comes from social psychology. And a sense of worthlessness actually is motivational. It can help you. Like, think about a physician who makes a serious medical error, understands that he made it, and yet feels like, you know what? I'm God's gift to the medical sciences. Is that person going to be really motivated to make corrective changes to their behavior? No. A little bit of some low self-esteem actually can really help motivate those corrective changes. And that is something that the researchers in that area explicitly recognize, that loss of self-esteem can actually help young training physicians to learn from their mistakes and go on and be better physicians.
So if we can induce depression in a lab, this suddenly makes the idea of throwing antidepressants at people as a response to depression a little questionable. Am I right or wrong about that?
I think that's a great point, Brooke. The results that we had, which again suggest that this is a normal emotional response that even healthy young people have to social rejection, it makes it harder to argue that we should be giving people antidepressants, because the whole philosophy behind using an antidepressant is that there's something going wrong in the brain, i.e., it's not a normal response, and that we can potentially correct it by giving antidepressants. The idea that this is a normal emotional response, i.e., that the brain is not malfunctioning, is more consistent with the use of psychotherapy than with antidepressants.
So from your perspective, then what is happening when we're putting antidepressants into perfectly normal brains? I think you've done some work around cardiovascular issues and early death, and I'm just curious how you, as an observer and a researcher, what you're seeing as we are medicating normal.
To answer your question a little more specifically, I need to explain a little bit about how antidepressants, particularly SSRIs or selective serotonin reuptake inhibitors, work. These drugs are called selective serotonin reuptake inhibitors because they bind to the serotonin transporter, which is a molecule that is present on neurons that release serotonin to various forebrain regions. This serotonin transporter is not only found in the brain, it's actually found all over the peripheral part of the body, the periphery meaning all those parts that are outside of the brain. And so it's found in, for instance, lung cells and heart cells and muscle cells and in our gonads, in the intestine. Every major organ expresses the serotonin transporter. And what the serotonin transporter does is it allows serotonin to be transported into the cell that expresses it. So, for instance, in the periphery, there's a lot of serotonin that is synthesized in the gut, and then it is released into the bloodstream, where it can then be taken up by cells all over the body through the serotonin transporter. So, for instance, a lung cell can take up serotonin from the bloodstream through the serotonin transporter, and that just happens all over the place. So the interesting thing is that when we talk about a selective serotonin reuptake inhibitor, it means that the drug selectively binds to the serotonin transporter and does not bind to other transporters like the dopamine transporter or the norepinephrine transporter. So it's selective in that regard. But it's not selective enough, because the use of the drug is primarily, if we're trying to treat depression, is trying to bind to the transporter that's in the brain.
Wasn't that also like a little bit of a marketing trick when they were deciding how to brand it? That the idea that it was selective made it seem like they really knew what was going on?
Yeah, that's a good point. I believe that these drugs actually do reduce depressive symptoms, but they are not very effective at all. That most of the symptom reduction can actually be attributed to its placebo effect. But I'm not one of those who say that there's no effect.
This is where we can get into what are the trade-offs, what are the pros and cons, what is the informed consent we're not getting, because based on what I think you're about to share with us, it's not necessarily a trade-off that people realize they're making.
Right, exactly. And in particular, I mean, we could talk about all of the side effects of these drugs, and which are they're the unintended side effects, meaning the physician and the patient don't want them. They want the reduction in symptoms, but they don't intend all of the other ones. And there are lots of cognitive effects too that may be undesirable. But let's just focus on the peripheral side effects for the moment, because again, the selective serotonin reuptake inhibitor, the SSRI, it will, because it's not selective enough, it'll bind to the serotonin transporter wherever it is in the body. If you go to a country where pharmaceutical companies are allowed to directly advertise to consumers, like the United States, yet at the end of an antidepressant commercial, like for an SSRI, you'll hear a litany list of side effects, right? That really cover a broad range of physiological systems in the body. And they could include digestive problems, sexual functioning problems, attentional problems, cardiovascular problems, et cetera, et cetera. And, it just seems like random to those of us who listen to the commercial. But if you actually understand that the drugs bind to the serotonin transporter wherever it is, prevent serotonin from going into all sorts of organ systems, then you can start connecting the dots that, of course, these drugs are going to have side effects on a variety of systems, because the serotonin transporter is expressed in a whole variety of organs and organ systems. Now, I will say that the negative side effects are individually fairly weak, but because they are happening across a whole variety of systems, the collective effects can be pronounced.
Exactly. And also people's emotional state is more intense well, at least in withdrawal is what I'm thinking of. I mean, I'm kind of going somewhere else in my brain where it's like, okay, well, why is it that people start complaining of all of these things when they start coming off of the drugs?
In my mind, this is still like a frontier area of research. But there's a lot of, if you want to call them individual cases, like people who've gone through this, what happens after you discontinue an antidepressant drug like an SSRI, to know that what you've said is true. Understanding the mechanisms behind it that's the understudied aspect. But I could easily imagine that, what's happening is sort of like, it's kind of the reverse of what the side effects are. I mean, not everybody is going to experience all of the side effects that you hear at the end of an SSRI commercial, but collectively they're there. And we know that from all of the individual responses that can happen. And that, again, is just because the serotonin transport is expressed everywhere. So, yeah, the people's individual, side effect profile, whether they're going on the drug or coming off the drug, are likely to be highly variable and broad ranging. So, I mean, one of the things I think you were interested in or alluded to is the research. We've done a meta-analysis of studies looking at all-cause mortality on these drugs, as well as cardiovascular events like heart attacks and strokes. And in the paper that we published, we looked at these things separately. So, of course, one important cause of mortality can be heart attacks and strokes. But of course, some people survive those things. So it's important to look at those events, whether or not they led to death. So all-cause mortality means exactly that. And death due to any cause, even if we can't identify what the cause is. We also had reason to separate studies where the sample of people that the study looks at either involved people with pre-existing cardiovascular diseases, which could include things like atherosclerosis, but also chronic pulmonary obstructive disorder, diabetes, etc. And those who were otherwise seemed to be healthy or had no other problem other than depression itself. There was a significant difference in all-cause mortality between those two types of samples. So you can imagine in a sample that involves a general population, we're looking at the risk of death where people are not taking the antidepressant and those that are, and the same thing in samples where there's pre-existing CVD. In the pre-existing CVD samples, the antidepressants don't seem to increase the risk of death. There is no significant increase. Whereas in the healthy samples, the general samples without the selected for pre-existing CVD, there was an increased risk of death associated with the use of these drugs. The way I would interpret this is that the cumulative effects of SSRIs and other antidepressants on all of these systems in the body contributes to a significantly increased risk of death. In the CVD samples, you still have the same processes going on. They're still probably affecting multiple systems in negative ways, but there's a counterbalancing benefit from normalizing their platelet cells so that contributes to no net harm, if you will, in terms of all-cause mortality to taking an SSRI if you've got pre-existing CVD. So that's what the study showed. And we didn't know exactly how it was going to play out, but we did have the prediction that we should separate out these samples, and that's what we ended up finding.
Well, Paul, let's end this on a little bit of an up note. What does all of your work and all of your knowledge in the subject, how can that give people a little bit of hope in their recovery as they go forward in life?
So it's a great question. I think there is a lot of hope, but one starting point is if we think about depression as a normal response, think about how our diagnostic criteria, which seem to be pathologizing normal responses, may be doing a lot of harm because we're taking people with brains that are working normally and, for the most part, pushing them to use antidepressant drugs, which actually interfere with the normal working of the brain. And that's their whole point, is to disrupt how the brain is working. So the first thing is with a better understanding of depression as a normal emotional response to the problems that life throws at you, with that knowledge, you can use that to seek out better treatments. And I want to point out the difference philosophically, again, between antidepressant medications and psychotherapies like cognitive behavioral therapy. As one example. The disorder narrative that is common in our culture today is a good justification actually for the use of medications for the reasons we just talked about. The medications do disrupt how the brain is currently operating. And if the disorder narrative is right, then in principle, the medications could potentially correct what's going on if we've got the mechanism correct. On the other hand, psychotherapies, which are basically just as effective as antidepressant medication and may have more useful effects in terms of long-term use than the antidepressant medications, really don't work well under a disorder narrative because all of psychotherapy actually requires your brain to be working pretty well. Think about cognitive behavioral therapy if you've ever been through it. But for the most part, the CBT therapist doesn't try to give you answers. Rather, the CBT therapist encourages you to develop hypotheses about what you think is going wrong in your life or in the way you think about things. And the therapist encourages that through Socratic questioning. Okay, so Socratic questioning, being able to answer questions, the Socratic related questions, and to develop on your own hypotheses and then to test them, that's like the hallmark of scientific thinking. You wouldn't expect a brain that was working poorly to be able to do that well. And that's basically true of all psychotherapies. They require you to reason and understand reasoning, and you just don't expect that to happen with a malfunctioning brain. So the alternative to the disorder narrative, the idea that depression is a normal emotional response to problems, first of all, doesn't mean you don't need therapy. Like if you've got a sprained ankle or a broken ankle, your pain is normal, but you still may need to get some help. Same thing with an infection or starvation. The painful feelings are normal responses, and it doesn't mean you don't need help. In the context of depression, where it's socially triggered, you may need some help figuring out the complexities of your social life, okay, and what lessons to learn, etc. But none of that means that your brain is not working well. So with the normal emotional response narrative, it doesn't mean you shouldn't be seeking out help. In fact, painful feelings in response to problems are normal things. Seeking out help in response to painful feelings is extremely normal. Okay, so part of this is addressed to the clinicians in your audience. Particularly the clinical psychologists who would be primarily involved in, treating their patients with one form of psychotherapy or another. I would point out to them that one of the reasons why antidepressant medications have skyrocketed in prevalence since the 1980s, while psychotherapies have declined rapidly over that same time period, is because of the way the narrative about depression has changed, and it's viewed as a disorder. That disorder narrative, is naturally inclined to push the antidepressant medication thing, and the CBT or the psychotherapy is not it's hard to see how that works well when your brain is supposed to be malfunctioning. So I think the clinical audience, especially the psychotherapists, ought to care about this disorder narrative, and they ought to think carefully about the justification that they have in their own minds for why they're using psychotherapy. If you really think that it's a disorder, your psychotherapy justification doesn't really make that much sense, I'm sorry to say. So another thing that a psychotherapist can do, and I think both the potential patients as well as the therapists in your audience can find this really useful, is for the most part, I think, most serious, even serious chronic depressions are normal emotional responses. So as a therapist, what is a useful way of approaching your patient? With the disorder narrative, you usually say, under the idea that it reduces stigma, you don't have to worry about this. This is not your fault. You just have something going wrong in your brain that you can't control. So that's where the medication often comes in. But a different way of tackling this would be to say, you know what? This is a normal emotional response to really serious life events that are going on in your life. I would be worried if you didn't feel depressed over this circumstance. This is normal, and this is your brain telling you that you must spend time thinking about these crucial things in your life. And you know what? As a psychotherapist, I can help you with some of that. Think about the difference there. First of all, if you're a patient who is facing really serious problems in their lives, like divorce, financial problems, who's going to get custody of the kids, really, really complicated stuff. And then you're told that your brain isn't working well. Well, you're not only then become depressed over the stuff that's going on in your life, you get more depressed over the fact that your brain isn't working well. And how are you going to solve all your problems with your brain not working well? It just becomes really horrific. But if you tell your patient that you've got a normal response, you don't get that second level of depression over and above it. And the other thing about this is that this is a natural way to induce what is called in the literature the Therapeutic Alliance. It turns out that psychotherapies are all pretty effective in treating depression, and it's not because of the differences between the different psychotherapeutic styles. It's actually that something called the common factors, and one of those common factors across psychotherapies is just how well you like and get along with and interact with your therapist. And by telling your patient that you've got a normal emotional response to really serious things going on in your life, I think that is one natural way to build that alliance with your patient. As a therapist, sometimes patients don't know why they're depressed. And you ask them why, they don't really understand. They can't identify a thing. But you could ask them instead a slightly different question, and that is, what are you ruminating about? They ought to be able to answer that. And from a therapeutic perspective, that's a really interesting clue that you can use to help your patient gain some greater awareness of why they're actually depressed.
Thank you so much, Paul. Where can the world find you if they want to learn more about your work?
Well, I'm an associate professor at McMaster University. So you can Google my name, Paul Andrews, and McMaster University. So that's probably the best way.
Perfect. Well, thank you so much, Paul. Keep up the good work.
Great. Thank you for having me on your program, Brooke. I enjoyed it.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.